You're welcome, Prof. Boima. Dr. Amwaba, your presenter is online, so kindly take over.
Good morning, everyone. Can you hear me, please? Hello, can you hear me?
Yes, Prof. Prof, we can hear you. You're welcome.
Thank you.
So please, we are all welcome to our meeting today. Our Thursday Cardiology morning meeting brought to you by kind courtesy of Ghanaian Society of Cardiology. Our topic for today is Cardio-Reno-Metabolic syndrome. And it is a great honor to introduce our speaker for today, Professor Boima, a respected consultant nephrologist and head of department at the School of Medicine, University of Ghana Medical School. We are grateful to have him with us for this presentation, and we look forward to learning from his wealth of knowledge and experience. Prof. Boima, you are warmly welcome.
Thank you very much. So good morning, everyone.
You may take the floor.
Thank you. Good morning, everyone. So I think this presentation is going to take a slightly different turn from my previous slides that I used to present in your meetings. We would focus more on the pathophysiological link between all the components of this syndrome and how we connect this to the holistic approach to the management of the patient in terms of both non-pharmacological and pharmacological approaches for us to understand exactly what we are practicing. So it's a little different approach from what we used to do. So I have no disclosures. All the parts of this presentation are drawn from these studies that I've listed here. So nothing out of, and I'll go according to this outline today. So how do we look at CKM syndrome? Usually a connection between all the components of the syndrome, which include obesity, diabetes, chronic kidney disease, and cardiovascular disease. And the cardiovascular disease could be either heart failure, atrial fibrillation, coronary artery disease, stroke, and peripheral vascular disease. Historically, when you look at the American Heart Association, in 2023, they actually reconceptualized these whole metabolic diseases, or let's say metabolic and non-communicable diseases, as a stage of one large spectrum driven largely by adipose tissue dysfunction mainly, and therefore creating a kind of unified framework that will put all this together instead of us all sitting in silos, managing this as cardiologists, nephrologists, endocrinologists, etc. There should be a holistic approach looking at all these diseases together as in one complex and providing a holistic approach. So a CKM is an interconnection between all these components, from obesity, metabolic dysfunction, cardiovascular disease, and chronic kidney disease for that matter. In terms of epidemiology and burden, approximately 90% of US adults have CKM at some stage. And stage 2 is the most common. Approximately about 50% of Western adult cohorts have CKM, and 34% of those with stage 1. There's the initial stage where there is no risk, which we'll go through very soon, can progress even to stage 2. So emphasizing the need for us to really identify these people very early, institute some kind of management that will really slow progression or actually prevent progression over time. And it's number one cause of death. You put all these things together in one syndrome is really number one cause of death. And CKM is said to actually disproportionately affect ethnic and racial minorities, low-income populations, and those with sedentary lifestyles. The prevalence is rising globally in parallel with obesity and diabetes, which are key components of the syndrome. situating this within the CKD epidemiology as well, when you look at it, the CKD itself, the prevalence is rising. About 850 million people worldwide are affected by CKD. That's 1 in 10 adults, and 5 to 10 million people die each year from CKD. That's the 9th leading cause of death. It's projected by 2045, it will be the 5th leading cause of death. And the 10-year excess risk of mortality for CKD is about more than actually 47%, and 50 to 70% of those with CKD is really from non-diabetic causes, which largely fits our CKD population, because most of the CKD population in this part of the world is non-diabetic related. And prevalence of CKD in sub-Saharan Africa is about 14%, most of whom are very young people in their productive years of life. And common causes, as I mentioned, hypertension being one of them, glomerular diseases dominating the absence of diabetes. But we know that diabetes prevalence is rising and probably may become probably number 1 cause in future. We don't know yet, for that matter. So looking at it from the CKM point of view, how do all these things connect? Where does it start from? What mediated and what are the outcomes of all these things? The initiating injuries or initiating factors, we know all of them, and how we approach them is key and very, very important. So hyperglycemia, systemic hypertension, glomerular diseases, obesity, dyslipidemia, previous episodes of acute kidney injury, genetic factors, ApoL1 for that matter in our case, HIV, and then infections, all lead to some kind of amplifying mechanisms that really gives us the outcomes of the diseases that we are seeing. So for instance, increased risk of intraglomerular hypertension due to activation of your RAS. So when the RAS is activated, you have increased levels of angiotensin 2, for instance, which causes afferent arteriolar constriction, which increases the pressure within the glomerulus and causes intraglomerular hypertension. This can cause podocyte injury and lead to albuminuria and eventually drop in kidney function and all that. Then there's also an increased risk of tubular hypoxia. Proximal tubular level in the kidney actually is at risk, particularly for this kind of injury, due to the fact that at this level of the nephron, there is a high rate of metabolism. There's a high energy demand at this point in time due to the various active transport systems that are at this level or that are functioning at this level. And these particular active transports depend on energy in the form of ATP. So if for some reason the oxygen tension in this part of the nephron is very low, then the oxygen needed for this active transport may not be available, which can predispose the tubules to tubular hypoxia and eventually injury. In CKD, for instance, the oxygen tension at this level is impaired, is low. So eventually there's at a risk of tissue hypoxia and tissue injury, tubular injury for that matter. There's also a risk of mitochondrial dysfunction. Another very important factor in CKD is mineralocorticoid receptor overactivation, which can lead to sodium retention, which can lead to inflammation and eventual fibrosis. And what happens at this stage is that with the CKD, there is increased pro-inflammatory gene expression, which through transforming growth factor beta, connective tissue growth factor beta, factor for that matter, which actually causes the inflammation and the fibrosis. And this mineralocorticoid receptor activation also can lead to oxidative stress, production of free oxygen radicals, which causes endothelial injury with an attendant increase acceleration of atherosclerosis and therefore increased risk of atherosclerosis, cardiovascular disease in this patient. There's also a bit of complement activation in these patients, which increases the risk of glomerular disease. And of course, sympathetic overdrive, which occurs in this setting as well, which also increases the risk of endothelial dysfunction, atherosclerosis for that matter, and also heart disease. And these amplifying mechanisms result in various outcomes. One, glomerulosclerosis causes kidney function impairment, tubular interstitial fibrosis from the mineralocortical receptor overactivation, and these receptors of the MR are also present in the heart. So there's also a risk of cardiac fibrosis when this happens, and of course all this will lead to nephron loss with eventual progressions to end-stage kidney disease. I mentioned endothelial dysfunction earlier on, accelerated atherosclerosis with the attendant risk of atherosclerotic cardiovascular disease, heart failure, and also premature cardiac death occurring. So how do all these things interconnect? They are really, really connected, and there's actually a bi-directional relationship between all the components of the cardio-kidney metabolic syndrome. So obesity, I mentioned adipose tissue dysfunction as one of the main mechanisms that drive this CKM, and this actually leads to increased free fatty acid, increased leptin with increased insulin resistance status. And we know that adiponectin is supposed to actually decrease insulin resistance, but in in this syndrome, adiponectin levels are decreased. So it rather enhances the risk of insulin resistance, which mainly is associated with visceral adiposity, with an attendant increase or activation of your RAS. When that happens, it also really causes many other problems. One, exaggeration of the RAS, as we mentioned earlier on, can cause glomerular hypertension, podocyte injury, albuminuria, tubular inflammation, and fibrosis, which can lead to CKD with an attendant decrease in GFR, albuminuria occurring, fluid retention, uremic toxins, and then sympathetic overactivation. All these can lead to left ventricular remodeling, heart failure for that matter. And then also the same obesity with all these insulin resistance states I described earlier on can cause hyperglycemia with its attendant injuries, which will come to very soon. And again, of course, the diabetes itself with all these insulin resistances, oxidative stress can increase the risk of obesity. So there's a bi-directional relationship in that direction as well. We mentioned earlier on obesity with insulin resistant state can also increase the risk of CKD, but CKD can disrupt metabolism as well and increase the risk of insulin resistant states, and vice versa, also increasing the risk of obesity as well. And there's also that bi-directional relationship between CKD and cardiovascular disease, which we all know already. So all these things are linked and interconnected. Diabetes with attendant hyperglycemia causes glomerular hyperfiltration, advanced glycated end products with attendant increase in oxidative stress with production of free radicals can cause inflammation, endothelial dysfunction for that matter, and cause cardiovascular disease or kidney disease for that matter. So these things are all interconnected. Obesity the same way through all these mechanisms I mentioned earlier on can cause cardiovascular disease. So they are all linked and interconnected. And it's important for us to understand that we to understand these mechanisms to inform how we determine our treatment approach, how we determine our drug selection approach to actually target all these multiple mechanisms in order to see if we can, in a way, slow down the progression of the CKM syndrome, of the heart disease, of the kidney disease, etc. So with that understanding, where do we target in terms of our drug selection, for instance? So I mentioned that there's RAS activation, which can lead to efferent arteriolar constriction, and therefore can cause glomerular hypertension and podocyte injury with attendant proteinuria. So here is where your ACE inhibitors really come into play to block this mechanism to decrease the risk of glomerular hypertension, podocyte stress, and proteinuria. So this is really where is the role they play in terms of slowing down progression of kidney disease. And the other thing I mentioned was mineralocorticoid receptor overactivation in CKD patients, which I said can cause inflammation through transforming growth factor beta connective tissue growth factor with oxidative stress, and also attendant fibrosis in the interstitial or cardiac muscles as well. So this is where, again, your mineralocorticoid receptor agonists come to the picture by inhibiting this receptor and therefore probably moderating this or slowing down the events that lead to progression of kidney disease or inflammation in the heart as well. And then also, of course, I mentioned tubular hypoxia, mainly at the proximal tubular level, due to energy dependent, and in CKD, oxygen supply to this area is low already, so there is low oxygen supply to this very high energy dependent part of the nephron. So in that, the nephron at this point is at risk of injury, but SGLT2 inhibitors decrease reabsorption of sodium glucose at this level, and therefore decrease the workload at the tubular level, so decrease the oxygen demand, and therefore tend to protect the kidney at this point in time. And at this point in time, so here again is where these drugs also come to play, and they have other benefits which I'll tell you very soon. And other studies have shown benefit in terms of the SGLT2 inhibitors, also inhibiting or perhaps slowing down complement activation. Perhaps that's the reason why some of the studies found benefit for the SGLT2 inhibitors in patients with glomerular diseases as well. So all these mechanisms were targeted in terms of how we approach them by way of how we select our drugs or how we target multiple points of the CKM syndrome to block them, may slow down progression of kidney disease and have cardiovascular benefits as well. So with that understanding, the American Heart Association, American Cardiology Association, Diabetic Association, and the American Society of Nephrology came up with a unifying framework that improves our understanding of how to approach these patients, when to treat them, how to treat them, etc., and etc. So it tells us how to stage it and also how to risk stratify these patients. So stage 0 is a healthy person with no metabolic risk factor or impaired GFR or proteinuria. Stage 2, they are at risk, so they may have overweight or pre-diabetes, no CKD or CVD at that stage. And stage 2, they have CKD or metabolic syndrome at this point in time, so they may have hypertension, diabetes, obesity, and CKD G1 to G3A, plus or minus the CVD risk at this point. And stage 3 is advanced CKD plus heart failure, so they have CKD stage G3B to G5, heart failure or high risk CVD at this point. And then for stage 4 is the advanced or is a stage where they have cardiovascular disease or kidney failure. We established atherosclerotic cardiovascular disease, or they are on dialysis, or at this point they may have had a transplant as well. The 10-year excess mortality risk for CKM syndrome is more than 47%. Now, if we take just one component of the syndrome, the mortality risk is probably low, about 7.7%, for instance, for diabetes. For CKD, it's about 11.5%, but once they have more than one of the components of the syndrome, say for instance, CKD plus diabetes, they have excess risk of mortality. For instance, if you have CKD and diabetes, your mortality rate is about 31.1%. So the more components of the syndrome you have, the more your risk of mortality, which really emphasizes the point of catching this very early, preventing it at the stage 0 stage or very early stage 1 stage, instituting some kind of measures that will really slow down the progression of the CKM syndrome to other stages. With that at the back of our mind, the CKD also have a way of risk stratifying the patients who have CKD and may be at risk of progression, may be at risk of cardiovascular disease. And the classification or stratification is based on GFR criteria and also albuminuria criteria. Of course, it's based also on etiology criteria, but we'll not talk about that now. So by way of GFR criteria, it's from G1 all the way to G5. And then albuminuria criteria is from A1 to A3. When you look here, even at high levels of GFR, say above 60, once you start having proteinuria, say from A2, as you can see, let me just use my pointer so you can follow me. So from here, even with higher levels of GFR, as long as you have proteinuria, you still have a risk of progression, you have a risk of mortality, you have a risk of cardiovascular disease. And the higher the proteinuria, the higher your risk status for this patient. The lower your GFR, the higher also your risk status. So those with advanced stage of kidney disease with proteinuria have a very high risk of mortality, very high risk of cardiovascular disease for that matter. So that's really key and very important for us to diagnose these people very early, on a very early stage, even when they have very high GFRs above 60, but have proteinuria, and take appropriate measures to target the proteinuria, to target slowing down progression of kidney disease, to target the blood pressure, target the sugar, target all other comorbid conditions in order to slow down progression of kidney disease. This is key and very important and in the management of these patients. So if we take this patient who is 55-year-old diabetic for the past 12 years, presenting with pidal edema and frothy urine, he was recently diagnosed of hypertension and currently on only metformin and amlodipine, blood pressure 145/90. How would we assess this patient, risk stratify this patient? What would be our management approach? How would we optimize the management of this patient? So it will require some kind of assessment in order to really risk stratify the patient. So his current lab shows HbA1c of 8.9%, obviously uncontrolled, so there's work for us to do. Uric acid level of 567. And uric acid can cause progression of kidney disease, so it's a need for us to target it. And then eGFR 45, again, which shows that it has come from renal, of course, has kidney function impairment. And albumin creatinine ratio is 98 milligrams per gram, which is high, and has ECG showing left ventricular hypertrophy, two-wave inversion, lateral late, and left axis deviation, BMI, which is high. So how would we stage these patients by way of the KDIGO heat map I showed you, and also by way of the CKM staging that I showed you earlier on? So when we use the KDIGO heat map, for instance, this person's eGFR in the question I put up earlier on was 45. So that puts him in G3A already. And then the ACR was 98. So that also put him in A2. So when you look at the two together, G3A, A2, it falls right here. And that is a high risk patient, so high risk of mortality, high risk of progression to kidney failure, high risk of cardiovascular disease. And this is somebody we need to prioritize, optimize treatment to reduce their risk of progression, their risk of mortality, and then their risk of cardiovascular disease progression as well. So when you take all that information and we want to stage it in a CKM syndrome, this patient has CKD G3A, which already falls in stage 2 CKM, as you can see over here. Also has hypertension, diabetes, and of course, even though the BMI is not obesity, but it's overweight, it still falls within this particular domain. ECG is already also showing some degree of cardiovascular heart disease, so it falls really within the stage 2 CKM, and this is also helps us to actually understand how our treatment, our management approach, holistic management approach should be for this particular patient. So with that at the back of our mind, we understand that we need to know when to treat, who to treat, when to treat, how to treat them. And that guides the appropriate intervention that we give to this patient. So if it's stage 0, primordial prevention, preserve health, lifestyle modification, weight management, very important for stage 1. In fact, it's important for even stage 0 as well. Stage 2 here, pharmacotherapy initiation is key, very important. Depending on what we have, we may depend on which drugs we need to use in order to slow progression. Like I said earlier on, it's important to have all the components of the CKM syndrome, target the various pathophysiological mechanisms we discussed earlier on in order to be able to block all the points to see if we can slow down progression, maximize the renal protection, cardio-renal protection that we give this patient. And of course, if at stage 3, you want to intensify the cardio-renal protection, so you may add, for instance, a non-steroidal mineralocorticoid receptor agonist. Of course, stage 4 includes everything else, including multi-drug therapy, including multidisciplinary care, cardiologists, nephrologists, endocrinology, dietitian for that matter. They are all needed when it comes to the care that we provide for this patient. So it's key and important for us to re-stratify, stage the patient, understand where they are and what their risks are in order to be able to manage them in a way that we need to manage them. There are various tools that we use to determine their rates in terms of risk calculator. This one I find very important and necessary for this presentation because we are dealing with CKM, and it seems to incorporate some of the components of the CKM syndrome. So I just put it up for us to all of us to have a look at. It's called the American Heart Association Prevent Calculator, which I'm sure most of you know already. And so it integrates the EGFI. It actually also integrates the UACR if you look at the whole equation, and then estimate 10-year and 30-year CVD risk. It's validated across all CKM stages and diverse populations and replaces all the previous equations that we know, and aligns with CKD staging to guide treatment thresholds as well. So we can all look at this as a risk assessment tool that we can use for our patients. With that understanding, KDIGO actually looked at the whole patient in terms of their risk of progression, in terms of the components of the CKM syndrome, and suggest how to actually manage them. So from lifestyle modification, weight management, low sodium intake of less than 2 grams per day, exercise, as we know how to advise our patients already, and cessation of smoking is a key components of their advice. Then RAS blockade, as we already know, is important in target BP control, less than 130/80. Then, of course, SGLT2 inhibitors with a level of evidence of grade 1A for both the SGLT2 and RAS blockade. And then also now we actually know the benefit of the non-steroidal mineralocorticoid receptor agonist that was initially approved for type 2 diabetes, but with the recent FINE CKD trial, which came out a few months ago this year, we know that it's also beneficial for non-diabetic CKD patients. And of course, statins, GLP-1 receptor agonists, PCSK, where indicated, BP agent to control BP and sugar for that matter, control anemia and acidosis. These are key and very important in the holistic approach to the management of the patients who may have CKM syndrome. What are some of the mechanisms that inure to the benefit of the patient when you are using SGLT2 inhibition, for instance? So number one, it increases sodium chloride at the macular densa because it inhibits this at the proximal tubular level, so it increases delivery at the distal tubular level, therefore increases macular densa, senses it at increased sodium chloride delivery at that point, and therefore causes a release of adenosine, and which releases angiotensin 2, therefore would lead to afferent arteriolar vasoconstriction, which decreases flow of blood into the glomerulus and decreases pressure within the glomerulus. So it helps to decrease intraglomerular pressure and therefore reduces the risk of intraglomerular hypertension, which is one of the pathophysiological mechanisms for CKD, and therefore also helps to slow down progression of chronic kidney disease. Again, also, like I mentioned earlier on, at the proximal tubular level, it's very highly energy dependent. So, and in CKD, oxygen delivery to this point is impaired already. So in order to decrease the oxygen demand here, SGLT2 can be of benefit. It decreases glucose and sodium reabsorption at this point, decreasing tubular oxygen demand and increasing cortical oxygen delivery. So this offers some protection from ischemia due to tubular injury. And of course, it has anti-inflammatory properties as well, decreases nuclear factor kappa beta activation, decreasing intrarenal complement, as I mentioned earlier on, and reduces tubular inflammation. And this was found when in the EMPA-CKD study. So it really may have some benefit because of decreasing the intrarenal complement activation, which may be beneficial in patients in non-diabetic CKD patients who have glomerular disease, for that matter. It also has some hemodynamic effect, because we all know that it causes osmotic diuresis, therefore may decrease preload and afterload. And sometimes also it's been found that it can increase erythropoietin-like effect, so it may increase your HB and therefore improve your outcomes in terms of cardiovascular disease management, decreases sympathetic tone, and decreases uric acid as well. So it has all these other benefits. It has effects in terms of providing alternative fuel for the mitochondrion by way of increasing ketone body utilization and increasing mitochondrial efficiency in cardiomyocytes and tubular cells, therefore lead to less apoptosis. Again, its anti-fibrotic effect, decreasing angiotensin 2, decreasing TGF-beta-1 signaling, lead to less interstitial fibrosis as well. And I think that this may actually complement the mechanism of the non-steroidal MRAs, because they also have anti-inflammatory effects. So combination of these two drugs perhaps may provide some kind of synergistic effect in terms of the cardio-renal protection that we seek to give our patients. So using the EMPA-CKD trial as an example, we all are familiar with this, so I'm not going to go into details. I'm just going to point out a few key points. It selected people of ages 18 and above, people with GFR between 45 to 90, and UACR more than 200, and some people with GFR between 20 to 45 as well, whether they have protein or not. But notable is that at 54% of this population in this study were non-diabetic, and they have some type 1 and type 2 diabetic patients as well. Some people with glomerular disease as well were included in this study. Their main primary outcome was kidney disease progression or CV death. There were some secondary outcomes as well. And this study met its pre-specified efficacy criteria very early in the course of the study during the interim analysis, and therefore was stopped at that point in time. They randomized over 6,000 people for 2 years, during which by the time of the interim analysis was about two years, and 54% were non-diabetic and more than 99% completion rate from 8 countries. The mean age in this study was 63.9, and average GFR was 37.4, compared to previous studies which used higher GFR. And then, like I said, 54% were non-diabetic. 48% has ACRs within the range of 300 and below, and 27 had a prior CV disease or cardiovascular disease. 35% had GFR below 30, which is worth noting because we know that it's beneficial in people with low GFR as well. So they recorded a 28% relative risk reduction for kidney disease progression or CV death. Number 83 to achieve this was 28 among this population, which was quite remarkable. And all-cause hospitalization was also significant, was reduced by 14%, was significant as well. And progression to end-stage kidney disease or death from cardiovascular causes was reduced by 27%, which was also significant in this study. And of course, among the non-diabetic patients, again, it was at 18% reduction in these outcomes I mentioned earlier on, even though the effect size was more in the diabetic patient compared to the non-diabetic patients. Like patients with glomerular disease also benefited. And I'm mentioning this thing because our CKD population is largely non-diabetic. So if we are seeing some of these benefits, is really would fit our CKD or patient cohort demographic. Probably saying that these drugs may be beneficial for our patient cohort as well. And people with GFR lower than 30, as much as 27% of them also have a risk reduction in these endpoints. It slows down progression of kidney disease at a rate of 1.37 compared to placebo of 2.75. So that again is key and important, because as we seek to slow down the progression of kidney disease in this patient. Of course, those with albuminuria, they also benefit in terms of slowing down progression of kidney disease as well. In terms of side effects, of course, the serious hyperkalemia was lower in the SGLT group compared to placebo, which for obvious reasons we know the osmotic diuresis will cause excretion of potassium in the urine. So we expect that potassium levels may be low. This one, and the AKI level was slightly higher in the placebo compared to empagliflozin, though we expected the reverse, but this is what we see in this study as well. So if you look at the MRAs, non-steroidal MRAs, for instance, and how they also impact in terms of CKM protection. We mentioned the mechanism earlier on that it was mainly due to mineralocorticoid receptor overactivation in CKD, which is one of the mechanisms that occurs here. But in CKD, because of this overactivation, aldosterone levels are highly elevated due to RAS activation. And these, as I said earlier on, can trigger various inflammatory cascades that can cause inflammation, fibrosis, and tubular injury. Can also cause oxidative stress, endothelial dysfunction, and vascular disease as well, which I mentioned earlier on. So these occurs independently whether the patient has diabetes or not, explaining why there's the NMRAs may benefit both non-diabetic CKD and diabetic CKD patients. And how does these NMRAs compare with the steroidal MRAs? One, in terms of selectivity, they are highly selective for the mineralocorticoid receptor compared to the aldosterone receptor or progesterone receptor. So for that matter, they tend to avoid gynecomastia, avoid sexual dysfunction when compared to spironolactone. They are more potent when it comes to this receptor blockage compared to the steroidal MRAs. They are 500 times greater in terms of mineralocorticoid receptor affinity than spironolactone, because they are bulky and fits the ligand site and fits the pocket fully compared to the other ones. And therefore, the tissue distribution can be found in the heart and the kidney compared to spironolactone, and for that matter. So it provides a more balanced cardiorenal protection compared to spironolactone. In terms of the risk of hyperkalemia, lower risk of hyperkalemia than the steroidal MRAs at equivalent efficacy doses, and safer in CKD patients. Has really no active metabolites, unlike the spironolactone, whose active metabolite is carrageenan, which this one doesn't have. So relatively more safer in CKD patient when it comes to eliminating metabolites from the blood or from the system. And like I said earlier on, the non-MRAs were initially approved for type 2 diabetic patients, but recent study a few months ago, which was a phase 2 randomized double-blind placebo-controlled study involving about 1,005 patients in multiple centers, showed that. Sure, so let me just talk about the recruitment population first. So the population in this study, adults with CKD of non-diabetic etiology were recruited, and patients with UACR between 200 to 3,500 milligrams per gram were recruited as well. GFR of more or equal to 25 and less than 90 were recruited to this study. And they were all on maximally tolerated doses of RAS inhibitors. And the etiological agents for the patients with CKD in this study were hypertension, chronic GN, IgA nephropathy, focal segmental glomerular sclerosis, membranous, MPGN. And this actually fits our CKD demographic from Africa and Ghana, for that matter, which I say is largely non-diabetic. And they give finerenone either 10 milligrams when the GFR is less than 60, or 20 milligrams when the GFR is more than 60. And their primary endpoint was GFR slope, mean annual change from baseline to month 32, and the Key secondary outcomes were kidney failure, sustained GFR drop by more than 57%, and hospitalization for heart failure and CV death. So other exploratory measures explore a drop of, let's say, more than 30% AGFR reduction at month 6 was also another endpoint they explored. So what did they find? They found out that the rate of decrease was lower in the finerenone group compared to the placebo group, and the difference was 0.7%, which was significant. So there was 23% reduction in the key outcome, composite key outcome, which is kidney failure. GFR dropped by more than or equal to 57%, heart failure, hospitalization, and CV death, and which was significant. And exploratory outcome, as much as 56% on the finerenone group had a reduction in UACR at month 6 compared to 24.4 for placebo. And so the safety measures, I'll talk about it. So as I mentioned earlier on, when you combine the SGLT2 inhibitors and the non-steroidal MRAs, it may have a complementary effect in terms of the cardiorenal protection when you look at their pathophysiological mechanisms that I mentioned earlier on. So, for instance, SGLT2, we know it has effect on tubular glomerular feedback. We know it decreases intraglomerular pressure, tubular metabolic protection for the kidney, decreases hospitalization, and then there's malnutrition and diuresis, decreases potassium effect. We know that MRAs can cause hyperkalemia, so they may offset the hyperkalemia from the MRAs. And the MRAs, on the other hand, has direct mineralocorticoid receptor blockade, which decreases inflammation. And earlier on, I told you that SGLT2 also have this same inflammatory mechanism, which decreases, so the two can complement one another. And it has anti-inflammatory effect as well, decreases aldosterone-driven endothelial dysfunction, and also cardiac and renal mineralocorticoid receptor protection. And therefore, with this hyperkalemia can be offset by SGLT2 inhibitors. So together, they may complement each other. And I'm sure there is probably a trial going on looking at the combination of these two drugs, which may provide a comprehensive CKD or cardiorenal protection for that matter. So looking at the management algorithm, we need first to, like we stated earlier on from the CKD stage, you first identify and stage all your patients, screen all hypertensive, heart failure patients, and diabetics for CKD using the GFR, using UACR, and stage the CKM from 0 to 4 and determine their risk status also, and determine whether the GFR is less than 60 or UACR is more than 30 for you to enable you decide on which drugs you want to introduce at each point in time. Then also the lifestyle modifications, key and very important at early stage. Maximize your ACE inhibitor ARBs when indicated and when not contraindicated. Level of evidence is grade 1. Target BP control. Low salt intake when indicated or when necessary. GLP-1 receptor agonist, especially when they are obese and have type 2 diabetes, and also statins when indicated, moderate to high intensity statins. Then SGLT2 may be added if GFR is more than 20. Start at 10. You may titrate the dose. Counsel on initial dipping of GFR when you start this medication. Then it's not a reason to discontinue the drug as long as the dip is not more than 30% from baseline. You don't have to discontinue this drug. You can continue even if the GFR falls below 20. You want to intensify the cardiokidney or protection, you may add finerenone, non-MRAs for that matter, and you introduce them. If the potassium is less than 5, you can introduce them at the dose of 20 milligrams.
Hello, Prof.
Yes.
Well, please, you have about 6 minutes.
Okay, then I'll just rush through quickly. So yes. I'm sure we are familiar with all these things, so I'll move on. And then from here, I will move on from there here. So we are familiar with the 4-pillar evidence framework for CKM protection, which includes the RAS blockade, SGLT2 inhibitors, non-MRA, non-steroidal mineralocorticoid receptor agonists, and also GLP receptors. And their benefits are all listed there, and why we should introduce them at various stages in order to provide a balanced protection for the heart and the kidney. And then the reason why we should block all these mechanisms in the CKM have been stated earlier on. And of course, this is something I wanted to do, but I will move on. We know the evidence already. Again, here I brought it because of how we need to monitor our potassium so that we don't unnecessarily stop the drug because of rises in potassium. There should be ways we can manage the potassium so we can maintain the drugs for the patient, the benefit that the patients would derive from it. For instance, using dietary restriction and using potassium binders. These some of them are not in our system, like patiroma or sodium zirconium cyclosilicate, but we can use the dye, you can use our calcium residuum, etc., and all that the other things that we have to manage the potassium so we can have a way of keeping our drugs. But if the potassium is very high, we still need to stop the drugs temporarily, manage it, and probably reintroduce the drugs at a certain point in time again. This evidence, we know all this evidence already, which which is important to take a decision regarding the use of the SGLT2 inhibitors. And the potassium management I mentioned earlier on, but the slides are here for you to look at so that we don't unnecessarily stop the drugs at any point in time. We have specific times when we have to stop them temporarily, treat the potassium, and bring the patient back again, which is key and very important. This one also tells us how to sequentially introduce these medications over time in order to maximize the protection that we seek to give these patients with CKM syndrome. Then this also shows the emerging benefit of triple therapy in terms of the SGLT2 inhibitor, GLP-1, and finerenone combination, which shows benefits when compared to monotherapy of any of this, and in terms of protecting of the cardiovascular protection, reduction in MACE compared to RAS alone, compared to other monotherapy, etc. Then this one also shows you when to hold which drug, how to give sick day advice. Rules and advice to your patient, etc. Emerging therapies will depend on many these drugs. There is still residual cardiovascular risk for our patients, so there's a need for emerging therapy. There's a need for complete organ protection, because with the current drugs, we still have incomplete organ protection. There's a need to look beyond type 2 diabetes, which most of these studies recruited, and consider all other CKD phenotypes from obesity to type 1 diabetes, etc. There's a need to look at weight ceiling as well. So these are reasons why emerging therapy is still very important. The incretin advances in terms of GLP-1 plus amylin, which is a semaglutide combination, a tirzepatide, which you know about already. The oral GLP-1 is on its way coming, which is the orforglipron, which has been shown actually to have equivalent efficacy with the injectable, which is also on its way. Triple agonist, which is the retatrutide, and I'll show you that also very soon if I have time. Confidence in study, which shows that the combination of SGLT2 plus finerenone is better than monotherapy as well. And all these other ones, the aldosterone synthase inhibitors are also on their way force, particularly for resistant hypertension, which is important because this also can cause progression of our CKM syndrome that we are dealing with. So baxdrostat and then lorundrostat, and the combination of baxdrostat and dapagliflozin trials are ongoing, which is coming soon. And the precision medicine in terms of digital AI strategies are also coming on. So the tirzepatide I mentioned has already been used for renal protection, and it's already around, but maybe it's not available in Ghana. Retatrutide, which is a triple agonist, the GIP plus GLP-1 plus glucagon receptor agonist, shown 24% reduction in weight. And also and then I mentioned orforglipron, which is the oral version of GLP-1. And also mazdutide, which is GLP-1 plus glucagon dual agonist, and also has strong hepatic benefit. And one of the things that which is yet to be properly addressed, is MASLH in the CKM syndrome. That's metabolic dysfunction associated steatotic liver disease, which is something some of these drugs are showing benefit for. So maybe the mazdutide and also the ecnoglutide is showing some benefit for those drugs as well. So these are things that are coming. And then, of course, we know the benefit of the semaglutide already, so we're not going to mention that one. We know the Fine Heart trials as well, and the their benefits in terms of cardiovascular protection and the benefits that we already know. I mentioned this earlier on, so I'm not going to mention it again. And then I mentioned also the DAPA-CKD in their benefits. We talked about the dual SGLT2, SGL1 inhibitor combination and their benefits as well. We can look at it, but there are emerging benefits for SGLT2, which is common for post-MI non-diabetes CKD, which we have already seen earlier this year. Obesity and CKD, MASH lead and MASH, which is also things that are really common. So the CKM spectrum is really expanding beyond what we know it already, and is including MASH lead or MASH and all that. I'm sure in the future other things probably will be added to all this. Now I'll move on, so I'll leave the slides for you to look at all these other things I mentioned earlier on. So CKM we need to look at it as a unified syndrome, emphasizing the shared pathophysiology, the need for a holistic multidisciplinary approach. A CKM staging and risk stratification is key and very important, using the EGFR, UACR, metabolic screening to catch patients before irreversible damage occurs. Early layered organ protection is key and very important, making use of your non-pharmacological measures, making use of therapeutic measures like RAS, SGLT2, and MRAs plus or minus GLP-1 receptor agonists backed by the EMPA Kidney, Fidelio, Figaro, CKD, and FIND CKD recently. And also complementary mechanisms of the SGLT2 and MRAs combination must be explored when it comes to managing these patients. A multidisciplinary approach is key and very important. We need to work together as nephrologists, cardiologists, endocrinologists, and dietitians to really provide a holistic approach to the management of these patients, and also take note of the upcoming emerging therapies that may really help us to provide the management that we need for these patients. So I'll stop here, and I hope that maybe in my next presentation, I'll be able to emphasize the emerging therapies better than we did today because of time. Thank you very much.
Thank you very much. Thank you very much, Prof, for this excellent presentation. Before we proceed, I would like to respectfully acknowledge the presence of our distinguished professors and senior colleagues on the panel. So from the various fields of study. So from nephrology, our presenter, Prof. Boima, Dr. Jello Inusa, Dr. Ba. And from cardiology, we have Prof. Doku, Prof. Ejekum, Prof. Nikose Jenin, Dr. Eugene Amable, Dr. Martinedu Adade, Dr. Abba Forsin, then Dr. Yakubu, Dr. Haji, Dr. Gordon, Dr. Awindago. And from endocrine, we have Dr. Pisade also on the call. And then from hematology, we have Dr. Harriet Koko. Thank you very much for joining. So at this point, I would like to take contributions from our panelists before we take questions.
It's Professor Jenny. Can you hear me? Hello, can you hear me?
You're loud and clear, Prof.
I can hear you.
Okay, thank you. So, Prof, this is an excellent talk. It's rare that I listen to talks and learn so much, and I really am grateful. I've got two very quick questions. Well, I don't know how quick the answers may be, but the first one, I'm going to ask both of them at the same time, although they are quite different questions. The first one is that mechanistically, finerenone sounds like it's going to be better than spironolactone. But of course, spironolactone has got so much data. So I want you to put your futuristic hat on. Do you think finerenone is going to replace spironolactone in management both of heart failure as one of the 4 pillars of heart failure and indeed in a lot of hypertensive patients?
Okay, so
that's my first question. Can I just add the second so I don't need to come?
Go ahead.
The second question is, the target for BP reduction in terms of maximum benefit is below 120/80, as shown in the trials that compared aggressive BP reduction versus standard BP reduction. But in my experience, it's so difficult to get patients to below 120 over 80 as a target without, a lot of misery. And I generally would tell my patients, listen, it's a question of whether you want to live forever, in which case I'll just keep adding medications, or, or you have you live a bit more comfortably, but you don't live as well. I just wonder what your approach is. So first of all is finerenone versus spironolactone, and the second is BP target. Thank you. Thanks so much.
So these are very difficult questions, but I'll try them. I think that the target, let me start from a target, for instance. I agree with you that it's so difficult to achieve such targets. If you look at KDIGO guideline for CKD with diabetes, CKD with other things, the target is usually less than 130 over 80. So for us, most of the time at the clinic, we still target less than 130 over 80. Achieving 120 over 80 is a difficult task, and I have really not tried to really do this honestly. And I also noticed that when we try to go much lower than that, in fact, our GFR sometimes tend to drop for some people. So in practice, you realize that if you try to stabilize the BP around 130, 80 and below, you probably would be able to keep the GFR stable as well. Sometimes when you try going down like that, you see that it's the wide fluctuations in the GFR as the patients come to the clinic. I from my experience, have not really tried to keep them at 120 over 80. I just use the KDIGO guideline to target 130, 80, and most of my patients are around 130 over 80 all the time. That's what I do. Regarding
thank God for that.
Regarding the futuristic big and then NMRA, I'll say that for the NMRAs, the data is still emerging. It sounds very promising mechanistically when it comes to the kidney, for that matter, and the benefit, especially for the non-diabetic population, and also for the fact that it is keeping it's more specific for the MRA receptor, and therefore some side effects such as gynecomastia and sexual dysfunction are lower in this population, and also the risk of hyperkalemia is much lower compared to spironolactone. However, for the cardiac benefit, I think the data is still emerging, so I would not say that at this point in time it's going to totally replace spironolactone and the Eplerenone. Future researches perhaps may come out with data to show us that, or perhaps say that the efficacy for both is equal. I don't really know what the future holds in terms of what data may come out later. But at this point in time, I think the kidney benefits, yes, but the cardiac benefits, I think the steroidal mineralocorticoid receptors still have a role to play.
So very quickly, can I just ask very quickly? Forgive me. So if you had your heart failure patient with, and you and I have a mutual patient who couldn't tolerate spironolactone, and we switched to finerenone. But my question to you is, if you had a heart failure patient with an eGFR of 30, what would you go straight for finerenone, or would you try a spironolactone first because of existing data, and then switch if they don't tolerate it? What do you do?
This is a difficult question, but personally, if you ask my candid opinion, once they have the RAS blockade in place, once they have the SGLT2 inhibitor in place, I probably, by default, if you ask me, go for the NMRAs before the spironolactone at this point in time. If it's heart disease, I know you will do the opposite, but for me, I think this is what I will do.
Yeah, that's really helpful. Thank you so much. Thank you.
Yeah, because of time, I wanted to cede my question, but if you want me to ask, then let me go ahead. Prof. Boyman, this is excellent. Just to congratulate you for this presentation. I've learned a lot, as Nick said. My question is in twofold. One, if you look at the population which can benefit from GLP-1 inhibitor, SGLT2 inhibitors, and then MRA, is very, very small, very tiny, less than 1%. So looking at the CKM approach, where do we position our intervention to have the maximum effect, looking at the disease progression, the patient journey? Because most patients are on the National Health Insurance scheme, and these drugs are not covered. So in the CKM approach, where should we be focusing on? Extreme right or extreme left? And my last question has to do with the multidisciplinary team approach to managing the CKM, especially the advanced stage. These patients see us at different clinics, renal clinic, cardiology clinic, but what would be the best approach? Should it be that I see patient and then get the views of the others, or we come together? What would be the best approach for this multidisciplinary team approach to managing CKM, especially the advanced one? Over.
So let me take the first one first. Where do we position ourselves in the CKM stages? I think it's key to look at prevention. Prevention is always better than cure. Prevention is always less costly compared to when they advance to the most advanced stages. So positioning ourselves at the early stages of 0 and 1, identifying the people, screening more frequently, identifying the people very early and putting in measures, 1, to prevent, 2, to identify the risk factors and treat them to target is key. So from the primary care level, secondary care level, we need to strengthen these places where there are a lot of chronic disease clinics like diabetic clinic, hypertension clinic, etc. Put in screening measures for early detection and early diagnosis, and instituting measures to delay progression at that stage, or perhaps identifying people and preventing the end organ damage from occurring. So I think that's really where we need to position ourselves. There's also a need for us to know that even when people progress, they still will need our help in one way or the other. So even if they progress to stages 3 and 4, what help can they get? Number one, we need to advocate for NHI, some of these drugs, to see if they can put them on their benefit package or not. Number 2, now we have Ghana Medical Trust Fund. If we can approach them so that they can sponsor some of these drugs for some of these patients, I think that it will maximize control and management of these patients and make life easier for us who are trying to manage them in the first place. Then the second question, the second question was what? I apologize.
The best approach to this multidisciplinary.
The best approach is one to work as a team. Where do we come together as a team, run our clinics together, refer patients to each other? That is going to be difficult, because imagine you see a patient now, you finish with the patient, now you are referring the patient to me. It's going to queue at my end again, another burden of waiting long time in the queue after having seen you, or perhaps paid consultation at your end, now coming to my end to pay consultation, see other people, multiple people. So that's really both physical, psychological, emotional, financial burden on one patient, seeing all these individuals who manage people in a CKM syndrome. So there's a need for us to have a unified guideline that can guide our practice. So when, for instance, the cardiologist sees the CKM patients, he can manage until a certain stage before referring or to the nephrologist or seeking the nephrologist's opinion. Then vice versa for the nephrologist as well. He can manage to a certain stage before saying, oh, go and see Prof. Doku, go and see Prof. Denin, go and see Prof. Ajekuma, etc. We need to come together as both GKA and Ghana Cardiology Association, sit down and have a unified guideline that this is the way we are going to manage CKM in Ghana, and this is the criteria we are going to follow. Otherwise, when we keep referring patients from one place to other, in fact, even if you want to call for advice on the phone, how many patients can you call for? Imagine you are seeing 10 patients in the clinic. Are you going to call for like the 5 or 3 patients? It will be inconvenient for you and the patients you are seeing. It will be inconvenient even for the person you are calling, because he or she may also be running a clinic. So I think there's a need for us to come together, have a unified guideline that will guide our practice, and we know when to refer and to what extent we can manage the patient before referring.
Yeah, Prof, I think this should not go without action points. So what I will do is I will ask Dr. Nikwe, Dr. Isifu, and then Dr. Inusan, and then maybe Dr. Fifi Dudu from the stroke unit. As quickly as possible, contact us. Let's look at how we can proceed with this CKM guideline, cross-cutting guideline for the various disease entities. Thank you. So I think if they fall head their names, let's take this forward. This is a very important recommendation from Prof. Boyema. Over.
Thank you very much, Prof. So there's a comment and a question from Dr. Chris Adey. Says, super excellent presentation, Prof. As always, very, very insightful and impactful. And he also has a question. Prof, with the clinical scenario of the patient you presented, given that there was LVH on ECG, will you upstage the patient to stage 3 rather than 2, as he has subclinical heart disease?
Yes, we can do that, plus or minus. The only reason I put the person there is because he has a G3A-CKD. But if he has atherosclerotic heart disease, or for that matter, we can push the person forward. At this stage, it's ECG, yes, but maybe if it's confirmed from other causes, why not? We can upstage the patient. I agree with that comment.
All right, Prof. Thank you. Please, if you have any question, you can lift your hand electronically. You'll be allowed to ask, or you can type it out. Dr. Chris Ade, please, do you have any contribution from the endocrine?
Oh, thank you very much. In fact, Prof has been super excellent. I don't think I have anything else to add. Thank you very much, Prof. Just to encourage my colleagues, especially the physician specialists and other primary care providers, to always try and stage patients. Nowadays, that is what I do. As Prof said, from 2023, this is the current model for managing such patients, so that we move away from this siloed approach. You put down like 4 or 5 diagnoses, but you never link them. But once you link them with the CKM syndrome and you stage, then just as Prof gave the management approach, you would always be in that mode to look at all the components and choose medications that will target all aspects so that the patient will benefit. And then you will not allow them to deteriorate from one stage to another. Once you always keep in mind that the particular patient in front of you has a unified syndrome and has a stage, and you do not want them to deteriorate further to the next higher stage. So that's all I would say. Thank you very much, Prof. It's been a super excellent presentation.
Thank you very much, Dr. Chris. Thank you. Prophet Jekum. There are no questions in there. Okay, there's a question from Dr.
Okay,
comment and a question.
I don't have any question.
Yes, please. So Dr. Inusa says, very insightful presentation as always, Prof. And then I think there's a follow-up. He says, we should interpret the BP target of systolic blood pressure less than 120 cautiously. The measurement of BP was not same as routine BP measurement. That approach is estimated to be about 10 millimeters of mercury lower. Thank you. But that's a comment from Dr.
Yeah, that point is well noted. I think it's important. Thank you.
Thank you very much. I don't know whether there are any further. Prophet Jukum, you have any comment?
Oh, no further comment. Just to say that it's been a very, very educative morning. And also to make a point, Prof, we have terzepatide in the country, so it's just that it's beyond the pockets of many people.
Yes, I think I know. I have a patient actually on
Mounjaro. Yeah, so as Prof Doku said, I think we need to come together and see how we can move it forward from here. Thank you very much.
Yeah. Thank you very much. Prof, any final?
Oh, I don't have any final comment, just to say that I think we need to work together as a team, because where this thing is going, it's no longer a siloed kind of management in our own corner, but it's calling for a multidisciplinary approach in the management of our patients. So we need to be managing our patients together. Or maybe perhaps we should push all the cardiologists to the cath lab and take over the patients. All right, thank you.
All right, thank you very much. So once again, I would like to thank our presenter, Prof. Boyema, and all our panelists and everyone for joining today's meeting. I also want to thank the Ghanaian Society Cardiology for hosting these weekly meetings. On that note, we will bring today's meeting to an. See you next week. Have a nice day, everyone. Bye.